Namaskaram and good morning everyone. Welcome to today's webinar, IAP Twin Cities branch postgraduate clinics. At the outset, regards on behalf of the entire executive board to all our IAP members who have been a remarkable support for all the IAP TCP programs, both virtual and also in person. And today's program Namaskaram and good morning everyone. Welcome to today's webinar. So today's webinar is a continuation of our promise to have postgraduate clinics every month. And these are very special discussions on a specific case for about 1.5 hours. Very rarely do we get the chance to discuss in detail one particular topic for an extended period of time. And it's also our privilege to have very good experienced teachers who are amidst us, who will be able to guide us on the program. One second. I also welcome all of you for our IAP Central Zone Pedicon 2022. We're just 2 weeks away, and the venue is at Hotel Park Hyatt in Banjara Hills, center of the city. We've all finished most of our obligations on the family front and also the medical exams for undergraduates and postgraduates. And we are hoping for excellent academics with good participation by all of you. We're very privileged and humbled that we have crossed 600 registrations, and probably the first time ever that we had to close registrations for a Central Zone conference 1 month ahead of the conference. Thank you all for the incredible support, and it only puts more responsibility on our shoulders to deliver an excellent and a memorable conference for all of us. We welcome you all in another 2 weeks to the city of Hyderabad for an excellent conference with the support of all of you. I now hand it over to our president, Dr. Sunkoj Bhaskar sir, for his inaugural remarks, and then we quickly move on to the academic session. Over to Bhaskar sir.
Yeah, thank you, Dr. RSV. Once again, I welcome you all for this 6th monthly IAP TCB PG Clinics, which we have been doing since January 2022. This is mainly intended for residents, fellows, and also practicing pediatricians to improve their clinical knowledge and skills. And once again, I stress during these PG clinics, our main aim is how to approach to the problem clinically, like history taking, physical examination, then evaluation and differential diagnosis. So these are the things wherein we stress in this scientific program. And I'm glad today all the faculty members are real academic stars. For instance, Dr. G.V. Subramaniam, I have been telling it since last several years, is an asset to IAP beyond any doubt. And whenever we request him to participate in any academic event, as a chairperson, as a speaker or a panelist, he will not hesitate for the position, but if it is an academic, he will come forward. That is the hunger he has, even after so many years of his experience and wisdom. On behalf of IAP TCB, sir, we sincerely thank you again for accepting to be here as a lead discussant and as well an examiner. And our Dr. Upendra Shava is a rising star in pediatric gastroenterology subspecialty, and he did his MD from PGI Chandigarh. Then he did his DM from Sanjay Gandhi Institute, PG Institute, Lucknow. Then he did his fellowship at AIG Hyderabad and as well at Rela Institute in Chennai. He is another knowledgeable, young, dynamic person. Thank you, Dr. Upendra, for accepting to be here as a lead discussant and as well an examiner. And our another faculty member is a well-known star across the nation, who is none other than Dr. Srinivas Murki. Needless to say about him, and words are not sufficient to describe about his academic excellence. I think we are all fortunate enough to have him among us, and he is the director of NSU at Paramita Children's Hospitals, and as well is in charge of academics like DNB Neonatology, Fellow Neonatologists, DNB Pediatrics, and various other academic activities. He takes lead in Paramita Hospitals. Thank you, Dr. Srinivas, for joining us. And our pediatric intensive Shagufta, she did her MD Peds from All India Institute of Medical Sciences. She's another brilliant lady who works relentlessly at our intensive care unit. And Dr. Somo, who is the presenter today, is a brilliant post DCH DNB student, and he is another upcoming academician. And today's case, I know because even I am from Paramita. It's very interesting, and it's going to be very, very interesting. It will generate a lot of discussion. So once again, thank you all for your continuous support for our IAP TCB academic activities. It is your presence and support which is pushing us and giving us strength, moral support to continue all these academic activities. Though our Honorary Secretary, Dr. RSV, told about our Central Zone Pedicon, I would like to add only one more thing, that is never before in the history of our academic conferences in Andhra, Telangana and Hyderabad, we have 14 pre-conference workshops which are very competitive with each other. And I'm sure I request all the delegates, if possible, try to join in those workshops. And that's really meant for true learners. So with these few words, once again, I sincerely thank all the participants. It is you VIP people who are giving strength us to do these academic activities. Thank you all, and I wish you all a great learning experience from our faculty.
Thank you, sir. Thank you. I'll now request Dr. Akhilesh to share screen. Akhilesh, could you confirm if both the mentors and also your guides are co-hosts? I see Dr. Subramaniam sir, Dr. Upender, Srinivas Murthy sir. Can't find Shagufta here as yet. Right. I think you can go ahead. The setting is so that only co-hosts can speak, but request all the participants to please actively engage in case discussion using the chat box. If you have any further queries, please put them up in the chat box so that we'll be able to discuss those points as well. Over to you, Dr. Akhilesh, and request the presenter, the guide, and also the moderators to take over the session. Over to you.
Good morning, everyone. I thank everyone, including my guide and today's moderators, Dr. Upendra sir and Dr. GVS Subramaniam sir. And I thank especially Dr. Bhaskar sir for giving me this opportunity to present my case presentation at the Iaptcb Pg Clinics. Myself, Dr. Soma Akhilesh Kumar Gupta, secondary DNB resident at Paramita Children's Hospital. Today, I'll be presenting case on infant with jaundice. Today I am presenting case of baby name as age 2 months 14 days, informant being mother, reliability is good, residence of Godavari Kani. Chief complaints, child presented with complaints of yellowish discoloration of eyes since 15 days, eye colored urine since 15 days, abdominal distension since 15 days, and pale colored stools since 4 days. If you are presenting illness, child was apparently well 15 days back, that is at 2 months of age, then developed yellowish discoloration of eyes since 15 days. It's insidious in onset, gradually progressive in nature, not associated with irritability or excessive cry. The high yellow colored urine since 15 days. It's 10 to 15 times per day in frequency, normal in stream, not associated with excessive cry while passing urine or decreased urine volume or oral intake. And according to mother, there was she noticed staining of diaper since 15 days. Previously, it was not there. The history of abdominal distension since 5 days, which is gradual in onset, progressive in nature. It's uniformly distended, not associated with vomiting, irritability, excessive cry, or any significant relation to intake of food, and there was no blood or mucus in the stool. Pale color stool since 4 days, not noticed previously, normal in consistency 2 times per day, initially lemon yellow in color as per mother and gradually turned into pale color, not associated with blood or mucus. This is the picture showing pale color stools. No history of fever, puffiness of eyes, or any peripheral swelling. No decreased urine output, dull activity, excessive sleepiness or irritability, feeding difficulty, rash, waxing and waning episodes of yellowish discoloration of eyes, bleeding manifestations, abnormal movements, or any vision or hearing abnormality according to mother. Past history, nothing significant from day 7 of life. Birth history, antenatal history, all ANC scans done told to be normal. Quickening was felt around 4 to 5 months of age. Weight gain throughout the pregnancy was around 10 kgs. Iron, folic acid, and calcium supplements were taken. No history of fever with rash in mother during pregnancy, pre-eclampsia or eclampsia, any increased hypertension or any seizure episodes with hypertension, any increase in sugar level, gestational diabetes. No history of hypothyroidism in mother or cholestasis of pregnancy or any acute fatty liver changes of pregnancy. Natal history, child delivered by a full-term lower section, cesarean section in view of macrosomia. Birth weight was 4.5 kg. History of neonatal jaundice on day 3 of life, for which single surface phototherapy was given for 3 days. No history of neonatal hypoglycemia, no history of neonatal seizures, or no history of any NICU stay. Mother's blood group was B positive and baby's blood group was B positive. Postnatal history, it was uneventful. There was no facial asymmetry noted or any peculiar order from the body or urine, or no obvious abdominal mass or murmur. Genitalia were normal. Immunization history, child as had complete immunization as per national immunization schedule. Dietary history, child was receiving direct breastfeeding plus Dexolac feed, 60 ml each feed, around 5 to 6 times per day, and they are giving 1 scoop, that is around 6 grams in every 30 ml dilution, and it's coming up to 337 kilocalories. Child expected weight is 5.1 kg, it's around 500 kilocalories with breastfeeding, and each tin was last about 1 week, that is 67 grams per day, and each tin consists of 400 grams. Developmental history, gross motor, child has partial neck holding at this age, and social and adaptive, social smile attent, recognizes mother, anticipates feet. Whenever we show brighter objects, child excites and seeing, and child blinks the eyes while switching on and off lights, and child alerts to sound. Family history, it's non-consanguineous marriage, first order birth, that is single female child. There was no history of repeated fetal loss or early demise, no history of neonatal cholestasis in parents, no history of any disease related to liver, kidney, or lung. According to modified Kupusami classification, they come under lower middle class. I want to summarize from my history. Here we are present case of 2 months, 14 days old baby girl, premorbidly normal, developmentally appropriate and immunized for age, presented to us with complaints of yellowish discoloration of eyes and eye-colored urine since 15 days, abdominal distension since 5 days, and pale color stools noticed from past 4 days. I want to present the differential diagnosis from the history. We are thinking in terms of any anatomical cause, as baby was active and no history of fever according to mother, and it could be biliary atresia, choledoculsis, and second cholestatic syndromes, which includes the progressive familial intrahepatic cholestasis or Alagille syndrome, neonatal hepatitis, could be infectious and non-infectious, the infectious and metabolic, and other systemic like sepsis, or genetic bile acid synthetic defects, alpha-1 antitrypsin deficiency, and could be idiopathic. General physical examination, child is active, alert, playful, vitals temperature 96.7 degrees Fahrenheit.
Shouldn't we go for some discussion now?
Yes, sir.
JVS sir and Dr. Upender, for your
Sir.
remarks and if any more information you need from the presenter.
Yes, sir.
I think
Hello.
we need some details
about the baby. Baby had it was large at birth, large in size, and baby is born full term. There was no issue of consanguinity. And is there any indication why they have made a switch over to some formula feed? There was no mention about the mode of feeding also. This also I think is important, especially the baby who is breastfed. And what was the indication for switching over to formula, and what was the mode of feeding? These things I would like to know.
Sir, in view of inadequate breastfeeding, child was started on the formula feed, sir.
Who has decided that breastfeeding was inadequate? The decision was made by whom? By the physician or by the mother?
Sir, by physician.
By whom it was advice was given? Mother.
Sir, according to mother, it was by physician only, sir.
Physician only. She thought that her milk was not sufficient, and physician has advised her to switch over to formula. What was the mode of feeding?
Sir, with palate feeding. Sir.
Palate only. They did not use the bottle at home.
No, sir, they didn't use bottle at home, sir.
Thank God. Okay.
Whenever they go out, they are using bottle. Whenever they stay at home, they are giving it palate, sir.
Okay. So the baby was fed with both. It's a mixed feeding. The baby was on, and urine output and other things were good. So among the differentials, what you have considered, they are prioritized. What you said is anatomical biliary atresia. Are they prioritized, or you just you pick up those conditions in which you come across conjugated hyperbilirubinemia as a routine?
Sir, I picked up general conditions which I come across conjugated hyperbilirubinemia, and according to the history, I thought so.
According to the history that you have started, right? So, what made you to push the infective and metabolic causes to the third in the order? Huh?
Sir, in view of child is not having fever, sir, and child from history, I could derive child is not sick looking, sir. By considering that had put my differential as neonatal hepatitis third, sir.
Less likely, as you said. So the baby was appropriately sized or even large for size also, and at the same time there is a less likelihood, and there was no issue of consanguinity, which is suggestive of any storage disorders. Less likely I can say. But at the same time, neonatal hepatitis kept it in. So are there any dysmorphic features that are suggestive of Watson-Allen syndrome?
No, sir.
Kept it in second place, huh?
No, sir. There was no no dysmorphic facial dysmorphism.
So Watson-Allen syndrome is also otherwise called. What is the other name for it? Any name you know? It's only just academic, of course, not related to case. Watson-Allen syndrome. Huh? Okay, it's all right. So you thought in terms of biliary atresia, choledochal cyst. And as per your history, you said there is no waxing and waning of jaundice, but initially the child was passing normal colored stool, and later on it turned to lemon yellow. Ultimately, the child started passing white colored stool, as you have shown in the photograph. Am I right?
Yes, sir.
So therefore, the stool color changed over a period of time and has turned to almost pale white. Is it not?
Yes, sir. Yes, sir.
So in the absence of pale stools, can you rule out cholestasis? In general, I am asking in general, not pertaining to this case. If a child passes even yellow colored stool, can you rule out cholestasis on clinical grounds?
Sir, if it's persisting beyond 2 weeks of age, sir.
Okay.
And sir, it's difficult, sir, up to sometimes this unconjugated breastfeeding jaundice, those all may last till 1 month age also, sir. It's difficult to elicit, sir. If it's beyond that, we could suspect, sir.
The stool on the surface, there may be seepage of bilirubin from the gut, and therefore on the stool, the pore may be white and surface may be yellow. So therefore, no doubt, white colored stool may be a very useful clinical pointer towards cholestasis. Absence of white color stool will not rule out cholestasis. Okay. Then what are the facts? So do you think is there a sepsis as a possibility here in this particular case? Sepsis, because baby is in a mixed formula. So when will you consider sepsis as a cause of conjugated hyperbilirubinemia in a clinical setting?
Sir, previously normal color stools and only acute history, sir. It's around 10 to 20, around 15 to 20 days history, sir. If child is not feeding well, if there is any autonomic instability, at that time we can consider sepsis as one of the possibilities.
Yes. So the sepsis is a clinical setting we will have because this is a full-term baby, normal size. Most of the times, if there is a sudden alteration in the feeding behavior of the baby, you have to consider first possibility as sepsis. But we must remember, sepsis is the commonest cause of conjugated hyperbilirubinemia after second week. Usually, it is one of the important causes in our Indian scenario. That is one of the important conditions. But in this particular condition, baby looks otherwise well. Though abdomen was distended, it was accepting feeds well. There was no vomiting. The baby was not lethargic. It was interested in the feeds and other things. Therefore, sepsis is, as you mentioned rightly, that is in the fourth order. And this is what I wanted to add little. Of course, the other conditions also have to consider. So over to other speakers. Apart from this, in history, when it is suggestive of child having possibility of a cholestasis, what are questions would be more pertinent for you to inquire for a baby who is presenting itself with an evidence of possible cholestasis? So you have to expect some degree of fat malabsorption, and once the fat malabsorption, you can ask for the history of some more questions that are pertaining to a state of cholestasis.
Sir, is there any oily color stools? I would like to ask, did they add any sugar to, they are giving formula feed, sir. Did they add any sugar to the feed, sir, like before giving feed?
Okay. What about the babies? So once there is cholestasis, there will be fat malabsorption. What vitamins will be deficient?
Sir, we expect fat soluble vitamins, sir, ADK deficiency, sir, vitamin A,
so
vitamin
what is the
D.
early vitamin that tends to manifest once there is a cholestasis? What is the which vitamin turnover is quite fast and scores are not much?
Sir, generally we expect vitamin K deficiency.
Yes.
Sir.
So what,
like
what questions would be pertinent in the present history to find out there is a vitamin K deficiency? What questions?
Sir, I would ask there are any rashes on the body, sir, and any bleed from ear, nose, and like the stool color, sir. Is there any blood stains, sir, like melena, any melena?
Bleeding from anywhere also you can ask for vitamin K deficiency. Right. Yes. Anything else? Once there is a cholestasis, what happens? What happens to bile salts?
Sir, bile salts accumulation occurs, sir. Bile salts
how it usually manifests?
Sir, child will be irritable, sir.
Irritable
and
you can also see because the child is little older, is around 2.5 months. So what else you will find? Baby has got marked cholestasis with a deposition of bile salts in the skin. You may find baby rubbing.
Yes, sir, baby rubbing, scratch marks.
You may find even sometimes scratch marks. Scratch marks they may be unusual in a small infant, but still you can make them. So therefore, the baby mother is finding child becoming more irritable, rubbing body parts with each other, and there is a bleeding tendency. That also are the questions which can be asked whenever you suspect a cholestasis in a small baby, right? So no doubt this looks more like some obstructive problem somewhere. If history presents like that, it may not be a medical condition such as sepsis. That's what I personally feel as per the history that is provided by you. And if other panelists they want to speak, welcome.
Good morning, sir. Excellent. As you were excellently discussing all the details, it's a relatively stable child. No clinical evidence of any hepatic cell failure or dysfunction. And as you were clearly discussing, even there is no clinical evidence of vitamin deficiency. So acute probability is a acute insult causing cholestasis in a relatively healthy child.
Yes.
Our differential should be based on this. So if it was the intrahepatic cause, metabolic liver disease would have been the initial differentials. And as you were telling, practically sepsis should be the first in all cases. In sick child, cholestasis, the sepsis should be the first, and second would be metabolic liver disease if the child is sick child, sir.
Yes.
So if, as in this case, if child is relatively healthy, so then extrahepatic causes would be the initial differentials. Yes. As it was discussing, any choledochal cyst or instated bile plug syndrome, or any biliary atresia could be the cause. But in this scenario, as the onset of jaundice is late, So unlikely to be biliary atresia. So it could be either choledochal cyst, as you are clearly saying, it could be some surgical cause with preserved hepatic cell functions.
Yes. So broadly categorizing sick child and well child. That's how we can. So sick means possibility of medical conditions are more likely.
More
Child
likely.
is otherwise well, clinically stable and hemodynamically stable. We have to think in terms of other conditions, as you said, like the metabolic disorders or storage disorders and surgical conditions. I think that we have to consider. That's how we can broadly categorize.
And the third group of diseases relatively stable could be some cholestatic syndromes, PFIC, and these syndromes can initially present with neonatal cholestasis, on long-term develop pruritus and severe cholestasis and decompensation on after a few months.
Yes.
So that first could be surgical causes, extrahepatic causes. Second could be cholestatic syndromes.
Yes.
And a third possibility could be some metabolic liver disease. This could be probably the priority of differential.
So we need to broadly categorize. And suppose the baby is unwell and it also looks sick, so we have to look for any hepatic decompensation evidence also clinically. So, but in this case, the baby looks well. There may not be need for looking for evidence of any liver cell failure. Suppose baby comes late to the clinical presentation, we have to look for evidences of any liver cell failure.
Yes.
So, Dr. Srinivas here.
Sir.
Sir, welcome. Good morning.
Good morning. So, I think is more or less very clear that in the case of cholestasis, I think there is no doubt in that because of the jaundice and the white stool. Second is, yes, it's a well child otherwise, but only point to ponder is what is this abdominal distension? This abdominal distension, is it from the history? What is this abdominal distension? It's a uniform abdominal distension or it's abdominal distension on one side of the body? Because if you are seeing abdominal distension and if it's a uniform abdominal distension, so what is the reason for that? Akhil, can you tell?
Sir, it could be like any like a fluid accumulation in the abdomen, sir. Like it could be uniform, or if it's localized to one part of the body, it could be due to any organomegaly, sir.
So this child had almost like a uniform abdominal distension, correct?
Yes, sir.
And they are saying it is progressive and it is gradually progressive, but the initial onset is only jaundice and then baby starts having abdominal distension. And it's gradually improving for the last 5 days, correct?
Yes, sir. Like very short history, sir.
So how do we explain that, Upinder, the abdominal distension, which is gradually increasing for the last 5 days? Should we think it in case of a liver cell failure or something else? Upinder, you're there?
Hello.
Yeah.
Sir. Am I audible, sir?
Yes, very much.
Hello. Sir. Yes, sir, sure. As you are discussing regarding abdominal distension, organomegaly and free fluid could be the two possibilities in this cell in the settings of cholestasis. Hello.
Yeah, you are audible, please.
Sir. So, as it was a uniform distension, most likely free fluid only, but the other features, usually when there is ascites due to liver-related disease, we sometimes see other edema, other parts, edema, fetal edema, facial puffiness, that or if it is male child, scrotal edema, all these more favors ascites. Otherwise, second point will be, it could be organomegaly. These two is the possibilities in this case. So, on examination, we will get the.
Yes. So, what I feel at the history level, if we make it out whether it is a generalized distension or a localized distension, if it is a generalized distension, it could be due to organomegaly, or less likely to be due to fluid accumulation because the picture is not presenting like that of liver cell failure or other conditions. So therefore, what I personally feel is At the history level, you can make it whether a generalized distension or a localized distension. Once it is a generalized distension, possibly it could be due to organomegaly, and we can corroborate with examination findings. That's what I think that would make. And there is another point I would like to make in this particular case is baby's growth was normal, so therefore there is a less likelihood of any intrauterine infection causing any hepatic issues. So for example, it may not be related to any intrauterine infection causing hepatitis or any other. So the baby's growth, so therefore intrauterine infections are also less likely. But once there is abdominal distension, we have to find out what is the cause, and that can be made out by examination to some extent, if necessary, supported by investigations like imaging. Right.
Next, coming to general physical examination. Child is active, alert, playful. Vitals, temperature, child was efebrile. It was 98.6 degree Fahrenheit. The heart rate was 124 per minute. Respiratory rate was 50 per minute. The capillary refilling time was less than 2 seconds. BP was 86 by 53 mm of Hg. That's coming to 258 cm between. And anthropometry, its circumference was 36 centimeters. It was between mean and -2 standard deviations. Length was 59 centimeters. It's between 50th to 85th centile. Weight was 4.9 kg. It's coming to 50th to 85th centile. Head-to-toe examination, the pallor was present, icterus was present, no clubbing, cyanosis, lymphadenopathy, edema, petechiae, scratch marks on the face or body. Shape of the head was normal, no facial dysmorphism was noted. Hair color black, texture normal, consistency normal. Height, deep icterus was present, no bite-out spots. Pallor was present, no cataract. Child has ability to fix and follow the moving objects. There was no posterior embryotoxin, cataract, or chorioretinitis on examination. Nose and oral cavity was normal. Neck, chest was normal. Abdomen was uniformly distended. Extremity and genitalia were normal. Coming to systemic examination. So first, I want to go with per abdomen examination. On inspection, abdomen was uniformly distended. Umbilicus was everted. Flanks were full. Skin over the abdomen was normal. Dilated veins were seen all over the abdomen. All quadrants were moving equally with respiration. Genitalia were normal. No earlier orifices. All orifices were patent.
Can you mention something about that dilated veins? Where they were? They were there all over.
Sir, small veins that could be visible all over the abdomen, sir.
Thin veins which are subcutaneous.
Yes, sir. Only subcutaneous veins.
Okay. Small veins were seen over the abdomen. Right.
Yes.
Then
palpation.
Continue.
Palpation. Child was there was no rise of local temperature. Per abdomen was soft, non-tender. The liver and spleen were not palpable because of generalized distension. There was no umbilical hernia. On percussion, dull note was noted all over the abdomen, able to elicit fluid thrill.
Ascites was there. You mentioned
yes, sir.
Huh?
Yes, sir. Yes, sir.
Ascites was there. Liver and spleen could not be palpated.
Yes, sir.
So no other masses you could feel because of distension, and umbilicus was everted. Right. Okay.
Yes, on auscultation, vowel sounds were heard. No bruit were heard. And other systemic examination in serious, we couldn't find anything abnormal, sir. And coming to RS, it was a normal vesicular response here all over lungs, and no added sounds were there, sir. CNS bilateral pupils were equal and reactive to light. The tone and alertness were normal, and no focal neurological deficits were there. So I want to summarize after total presentation. Here I'm presenting case of 2 months, 14 days old child, old baby girl, which was nil premorbid, developmentally appropriate, immunized as per age, presented was with complaints of yellowish discoloration of eyes and eye color during 15 days. Abdominal distension was there since 5 days, and pale color stools since 4 days. And on examination, there was pallor, icterus, abdomen was distended, umbilicus was everted, fluid thrill was there, and I couldn't elicit any peripheral edema in the child, sir.
There was no edema at all, no pedal edema.
Yes, sir. Yes, sir. Child had
The
a
small
healthy
babies,
look.
you have to look for skin creases, and they are not seen. Then we have to think in terms, because edema is not that easy to make out in a small infant. I agree. Right. Yes.
Sir, in like at the end of discussion, child in view of relatively healthy look from history and examination, I could elicit only abdominal distension, sir, and I couldn't see any synthetic dysfunction of liver, like bleeding manifestations or any edema, or compared to hemodynamics, scale was stable and there was no decreased urine output, sir. I would consider my differentials as follows in the next slide.
Before I think any comments about the examination part also, I think panelists can, anybody wants to. Sure.
So maybe sir and Upender can tell us how do we explain ascites in a child with cholestasis without edema? So are we dealing with liver cell failure, or is it any other cause for this edema or ascites? In a child, one would think of Budd-Chiari, hepatomegaly with ascites. So should we consider a liver disease or consider a Budd-Chiari like thing or any other illness?
In this case, I strongly suspect the possibility of Budd-Chiari, sir. The child looks otherwise well, but there was evidence of subcutaneous veins. Some observation is made with the presence of veins. There may be associated IVC, suprahepatic IVC obstruction also with Budd-Chiari is a possibility. And child has got a liver naturally because of ascites could not be palpated, but there is evidence of some congestive hepatomegaly is there that could be the cause for even intrahepatic cholestasis with ecolic stools. So I consider the possibility of a Budd-Chiari in this particular case.
Only point will be, sir, will Budd-Chiari have so much of jaundice, sir?
Too much of jaundice means we have to consider, sir, because I don't know. By Budd-Chiari, usually we come across with minimal hepatomegaly. Ascites also will not be marked. In this case, one point against that is marked ascites. He says the almost fluid thrill was there. There is a substantial fluid accumulation. That is one thing we have to think. Still, somehow the scale is tilting towards Budd-Chiari for me. Maybe I am wrong because I would not have seen many cases of Budd-Chiari. Honestly admitting.
So
yes,
maybe
sir.
Upender can help us. Upender.
Sir,
So
yes,
what
sir,
you need to tell us is this cholestasis and this ascites. How do we explain this? If it is not cholestatic related ascites, or if it's cholestatic related ascites, why are we not seeing other signs of failure like encephalopathy or bleeding tendency? Then if it is not cholestatic related ascites, what else is the differential?
Yes, sir. Yes, sir. As we were discussing, all the points are right, sir. This is cholestasis is clear, sir. In this child, we all agree that there is definite cholestasis and definite ascites. But usual scenarios are that when cholestasis with ascites is there, we definitely see other features of liver failure. As we are saying, skin bleeds will be there, encephalopathy will be there, anasarca will be there. So all these features are not there in this child. So it is most likely could be extra hepatic causes of causing cholestasis and ascites. So if it was intrahepatic causes like metabolic liver diseases or any cholestatic syndromes decompensating, or in sometimes storage disorders like Niemann-Pick type C or glycogen type 4 can present as neonatal cholestasis with decompensation, sir. So, but all these features have other features of liver cell failure. Growth failure will be there, skin bleeds will be there, anasarca will be there. But this is extrahepatic cause. When we look at the extrahepatic causes of cholestasis, then as with ascites, one is biliary ascites is one of the important, very uncommon, sir. But we see once a while we see. So ascites healthy.
Voice is not heard. Hello.
Hello.
Now it is audible. Yes.
Sure. This is child with cholestasis and ascites, sir. So, and no evidence of intrahepatic dysfunction or liver cell dysfunction. So, in this, we should think of causes as we were discussing Budd-Chiari, but usually Budd-Chiari don't have so much cholestasis. This can have ascites, but cholestasis is unlikely in Bursary. So that is post-hepatic. So we should also think of pre-hepatic causes like these bile duct causes, and biliary ascites is one of the known causes we occasionally see. So either spontaneous rupture of the biliary CBD or polydocal cyst sometimes presents with ascites due to rupture, or even very large polydocal cysts, very huge polydocal cysts, almost like 10 centimeters. These can also present like ascites cholestasis. So with this clinical scenario, healthy child, preserved liver synthetic functions, cholestasis and ascites. So my possibility could be uh, uh, biliary causes, extrahepatic causes. Either it could be large polydocal cyst or polydocal cyst with rupture, or sometimes even rarely there are reports of spontaneous rupture of bile duct presenting as ascites. These could be the possibilities because there are no signs of intrahepatic causes clinically.
Sir, one point I would like to mention, we have to consider in this case there is obviously there was no suggestion of liver cell failure. Child had definitely had an ascites, and apart from that there is an evidence of cholestasis. So what I personally feel is, as you said rightly, it is an extrahepatic or possibly post-hepatic cause. Like say for example, let us assume it were to be a Budd-Chiari syndrome. Child can have associated portal hypertension also, which would have the portal vein is large enough to cause obstruction of the CBD. That also may result in cholestasis, which clinically might have presented like that. So this is only my assumption. Maybe I am wrong. But what I personally feel is we have to explain the phenomenon of cholestasis to such a degree as to cause a severe clinical jaundice, apart from the evidence for extrahepatic cause for this cholestasis. That is one thing. That's what just is only assumption.
Yes, sir. So this,
I totally agree with sir. And Upender, while you are there, can you tell us at what stage of liver cell failure one sees ascites, at what stage one sees coagulopathy, and what stage one sees encephalopathy?
Sir, usually depends on etiology. These decompensation visa, once the child develops either ascites or coagulopathy, so we say it as decompensated liver disease, chronic liver disease. So some of the
can you tell us that it is a percentage of liver cell failure or total liver has to fail if you want to have ascites and coagulopathy?
Sir, it's difficult to say. Sir, this depends on etiology. We see these some of the metabolic liver diseases are there. So they present in neonatal period only with decompensation. So how fast the liver cells are destroyed depends on etiology. So this like neonatal hemochromatosis presents in acute liver failure, like presentation in the first week of life. Galactosemia is like usually presents in first few months, few weeks, 4 to 6 weeks of life. They start decompensating, so developing ascites. Once they are giving continuous on breastfeed from day one of the life, by 6 to 10 weeks, slowly in the second, third month, they develop ascites.
No, if you consider a chronic case, suppose you are considering a chronic case, say it's a chronic case of liver disease, what are how the liver cell failure will present? Which is the first thing, which is the second, and which is the last thing?
So initially they develop jaundice, first chain. So coagulopathy most of the time is a late manifestation.
Correct.
And ascites will be the middle. Once liver cell dysfunction starts, they develop hypoalbuminemia and portal hypertension. Both these contribute to ascites. So after that, they develop coagulopathy.
You need almost complete liver cell failure for coagulopathy and encephalopathy. Yes, but ascites may start once hypoalbuminemia sets in. Yes, and hypoalbuminemia can set in somewhere around 50% or 60% of liver failure.
Hypoalbuminemia is more an indication of a long-standing liver cell disease because albumin half-life is about 21 days.
Yes, sir.
For hypoalbuminemia to set in, it takes some time. So therefore, it is more evidence of chronic liver cell dysfunction rather than acute phenomena. So in the acute phenomena, I think we have to go more by biochemistry, especially, for example, in acute liver cell, one of the most sensitive indicator we take is, I think, if I am right, prothrombin time. So there is a tendency for acute liver cell failure biochemically can be detected much early. If there is a delayed prothrombin time, it's put to be there rather than going by clinical. That's what I wanted to add, sir. But one more thing, sir, I get a doubt because of my experience in newborns age group is less with regard to hepatic encephalopathy. as a neonatologist, how to suspect hepatic encephalopathy in a small baby, young infant, because the features are so subtle. Even an observant mother or a clinician is also likely to miss them. So, for the discussion sake, I'm asking how to detect hepatic encephalopathy in a young infant. I think both yourself and Upender, you are experts in this. I think you can throw light on.
Sir, I think that's not a difficult thing, sir. Encephalopathy in newborn will be poor feeding, lethargy, decreased activity, hypotonia, and maybe in some stages there'll be acidotic breathing and hepatic failure. But it is in a sick child. That's why we call it sick child. This baby is active, vigorous, sucking from the breast. So
not this baby, sir. In general, I'm asking.
So in general, it will be like that only, sir. Lethargy, poor feeding, decreased activity, poor suck, and hypotonia.
Because not all people, all babies with universal failure also may not have clinically detectable jaundice. Still, they may land it. See, we see some even Walter children also Rayleigh syndrome and others. We don't come across jaundice. Still, the patient may go in for acute universal failure. Just I got a doubt. So sometimes we may miss inadvertently evidence. That's what I wanted to know. Because the clinical aspects are more important. Of course, as you said, if the child is really sick, we have to do the necessary workup and find out. That is a different story. Right.
So, Upinder, does Bacchiari have cholestasis?
Sir, very minimal cholestasis. Usually, predominantly, it's a portal hypertension presentation. So, due to block of the hepatic outlet obstruction, the liver gets congested.
Sir,
and that leads to portal hypertension and seepage of fluid from the liver surface and ascites.
But my doubt is, if there is a congestive hepatomegaly because of hepatic vein thrombosis or because of Bacchiari syndrome, is there not a possibility of intrahepatic cholestasis occurring in a baby like this?
Sir,
See, liver will not intrahepatic
very minimal.
If liver parenchyma is swollen, biliary canaliculi are likely to get obstructed and may produce intrahepatic cholestasis.
Sir, this it can happen, sir, but very chronic cases. Bacchiari usually has two types of presentations. So one is acute Bacchiari and other is chronic Bacchiari.
Yes.
So acute Bacchiari presents like almost hepatic liver failure. Hepatic liver failure, very large congested liver, acute ascites and liver failure. Whereas chronic Bacchiari presents like chronic liver disease, slowly developing ascites, slowly deterioration of the liver function, slowly developing jaundice and encephalopathy, portal hypertension, sir. So in this case, if we suspect, it could be some acute Bacchiari like presentation, sir. So in this child, usually they don't have so much of jaundice clinically. Some biochemical hyperbilirubinemia may be there, sir. 2-3 bilirubin may be rise due to congestion, as you are saying. But clinically evident jaundice is unusual in acute Bacchiari, sir. Mostly it is hepatomegaly, congested liver, liver cell ascites. These could be the usual manifestations in acute Bacchiari.
Dr. Upender, what you said, I agree. It can present an acute presentation, but you are more, you may be throwing more light because if it has occurred because of some vascular event like hepatic vein thrombosis, it's okay. Suppose if it were to be due to some web or something, anomalous venous course or some anomaly within the hepatic venous system, if it causes Bacchiari syndrome, then also it will have an acute presentation like that. Or it can have a somewhat subacute presentation like this, as in this case.
Yes, sir. It may have gradually progressing ascites can be the manifestation in that. So slowly deteriorating liver functions. Initially they develop ascites and later they develop cholestasis.
Okay, solid. I think I refrain myself from further discussing here, but you can throw light if there is anything there.
Hello.
Yes, you can continue, sir.
Sir. Yes, sir. They can develop, but usually the initial presentation will be ascites, and later on they can develop cholestasis.
Oh, right.
So here, in this case, the presentation is otherwise round. First, she developed cholestasis, and then slowly developing ascites.
Yes.
So that is only one outreach. Otherwise, we would have one of the strong possibility as Bacchiari.
This child having a specifically, the observer has pointed out there are dilated subcutaneous veins over the abdomen. I feel, is there any vascular event that is happening like IVC thrombosis or something of that sort? I strongly suspect in this particular case because maybe we have to find out. Maybe I had macrosomia. maybe add any other hypercoagulable states also, I think we need to work out. That would have
Yes,
asked.
yes.
Please ask that.
Yes, sir. Yes, sir. So if yes, sir.
Yes, I think we can continue with the case. Sir.
Yes, sir. So finally, after all these discussions, our final impression between these two possible, sir, and everyone clearly agree that it is cholestasis with ascites and no obvious liver cell dysfunction. So we are thinking extrahepatic causes, either it could be biliary causes or ascites, hepatic vein obstruction. These two could be the final possibilities. So other unlikely causes like metabolic liver disease, some milder variants, or some cholestatic type of diseases rarely present like this. So at the end of this history and examination, we would have these differentials.
Yes.
Then we go with basic investigations and try to sort out the final.
Yes, exactly. Yes.
These could be differential, sir, like stable neonate, it could be biliary atresia due to polydocal fissure, any leak, and PFIC type 1 or type 2, and that could be bile acid synthetic defect. And if child is sick, we could approach in the following manner. Sir, after examination in view of relatively healthy, this could be differential diagnosis.
Yes.
Sir, as neonatal cholestasis, as well newborn, the child is active, it's not sick looking. Child has pale stools. Like we were in urgency to rule out biliary atresia, and we had done basic investigations which include hemogram, liver function test, PTINR, and CRP, sir, C-reactive protein, followed by imaging, ultrasound with HERA scan, and the HERA scan. And after seeing the reports, we followed as shown in the flowchart. Baseline investigation. This thyroid function test was normal. Urine microscopy and culture were sent. It was sterile. Urine for reducing substance was negative. Patch profile PCR we have sent. It was negative, and serum GGT levels were at 363
Here,
levels.
I have got a question to Srinivas Murthy sir and Upender sir. How to infer the GGT, gamma glutamyl transcriptase, in a small infant like this? I think that the adult values are not attained up to the age of 1 year, if I am right. How to go about, how to make an inference? Here it is obviously raised. That's H2 of cholestasis, I agree. It seems. But what is the normal range? You can Upender or Sir Srinivas Murthy sir can throw light. Sir is not there.
So I did, sir. So I thought Upender will respond, but yes, GGT has a very important diagnostic value in cholestatic jaundice. Two important differentials can be easily ruled out is PFIC and bile acid synthetic defects. In both these defects, when you expect cholestasis and low GGT, you can easily rule out these two conditions. Or GGT is very low in bile acid synthetic defects as well as in PFIC. So that's useful as a differential test. And PFIC can present even from the newborn period, and even bile acid synthetic defects can present as liver cell failure in the newborn. Upender, is that right?
So GGT levels, is there any age-wise variation, sir? Srinivas Murthy sir, my doubt. Because in infants, I think inference is somewhat subtle.
So we have normal values, sir. We have normal values for age-appropriate values. Yeah.
Okay. I think a normal range is 0 to 55 here. That is what is being shown.
Yeah.
Okay.
No, very low values are in favor of in a liver cell failure. Very low values in favor of bile acid synthetic defect.
Okay.
In a cholestasis, low values are favoring PFIs.
So there is obviously cholestasis here. You agree, sir? There is cholestasis here. Yes?
No, I didn't get it, sir.
Yes.
So these are high values. High values means obstructive.
Sir, shall I continue, sir?
Yes, yes. Continue here.
Sir, the hemogram as follows. Child got admitted to our center at 31st of May, and like before admission, hemoglobin was 10.9. WBC count was 12,000, and 30% and 65% neutrophils and lymphocytes respectively. And platelet count was thrombocytosis we have observed at the time. And on 1st June, like hemoglobin was 6.8 and WBC was 5,300. Differentials were 40% and 56% respectively. After this, we have given one CRBC transfusion. Post transfusion, hemoglobin was 10.6 and WBC count were within normal limits. And these were the reports, like serial monitoring of total LFT was done, like a pre-admission before presented to us. Child total bilirubin was 7.4. In that, direct bilirubin was 4.8. As newer guidelines, it shows greater than 1 mg per deciliter suggestive of cholestasis. Here, like it suggestive of the conjugated hyperbilirubinemia, and the albumin throughout the admission it was maintaining, and like we have done 2 interventions. One intervention at 31st, followed by there was decrease in TBDV, and one more intervention on 6th June, followed by we can observe there was decrease in TBDV level, total bilirubin and direct bilirubin, but synthetic function of liver was maintained throughout. And SGOT, SGPT levels we could observe only milder elevation which are insignificant, but they are maintained within normal limits. And total protein also it's maintained. In between there was waxing and waning episodes.
If we observe the trends, even the direct bilirubin is coming down over a period of time. Is it right?
Yes, sir. Yes,
4.8 to 1.1, and indirect bilirubin, of course, is going a downward trend only. SGPT remains more or less static, 57.59, and albumin was maintained throughout. So the synthetic functions, as you said, synthetic functions are going reasonably fine. Huh?
So no, sir. We have give the value because only for the first 2, because there is some intervention done after that.
Okay. Some interventions were done.
Sir, like aromos which are suggestive of 2 interventions we have done, sir. I'll be revealing what we have done, how we managed in further slides, sir.
Okay. Right. Agree. Yes.
No, this is not a thing which is without intervention. There is some
with the interventions, serial reports. Right.
Yes, sir. With interventions, 2 arrows are showing 2 interventions.
They are the interventions, right? Now I could see. Yes. Agree.
Yeah.
Yes. Go ahead.
And the PT-INR was within normal limits, sir. Like it was 15.9, 13.4, and 14.1, and INR was maintained in serial monitoring. And the CRP levels were like 53.2, 36.1, 16.1, and 69.1, sir, respectively. But child remained afebrile during this phase. For imaging, these are the imaging we have done. First fasting ultrasound followed by EDA scan. We have done echocardiography, which was normal. Chest X-ray was normal. Following that, we have done magnetic resonance with cholangiopancreatography. And USG abdomen was showing a liver of 6.8 centimeters. We could see irregular borders.
Akhil, after the ultrasound abdomen, you stop there for discussing the investigations and further discussion.
Yeah, sure. The liver of 6.8 centimeters, normal in size, echo texture, and mildly irregular surface noted, no focal parenchyma lesions. Intrahepatic biliary and venous radicals were normal. CBD appears normal in course and caliber. Pancreas were normal, spleen were normal. Impression was mildly irregular liver surface. Gross ascites with free floating internal.
So can we analyze the case now? Because what we have now is we have liver cell functions, we have features which were investigated for liver cell failure, and we have some etiologies which can clearly rule out. So maybe sir can help us, and Upender, you can add the point.
Dr. Upender, can you unmute yourself? Since you are a co-host, you can unmute yourself.
I think he's not able to do it. So, so I think first thing is, yes, there is cholestasis. Second, we know that it is a well baby. And on investigations, we find that there is significant ascites and there is irregular liver architecture. And
Hello.
Now we
Hello.
Yes, yes.
Sir. Sorry, sir. Sorry, there was some connection problem, sir. I could not unmute it. Hello.
Dr. Upender, we can hear you. Please go ahead, sir.
Sir. Yes, sir. Yes. This after this basic investigations, so liver function LFTs were showing as we were discussing clinically, sir. The synthetic functions were preserved with only cholestasis. So regarding GGT, I think it's elevated, so GGT. So usually in newborns till around 1 to 2 months of age, we normally see relatively higher GGTs. Around up to 200, it is normal. So slowly over time, by 6 to 8 months, it becomes to adult values around 40 to 70. So even in this case, I think it's more than 200 only. So GGT is elevated. Synthetic functions are preserved with cholestasis. So these were the findings which are closely matching our clinical difference. And ultrasound findings, one important finding we could see is there is some separated, but it's not clear ascites. So most of the time, either in Budd-Chiaris or chronic liver diseases, the ascites will be clear. So it's there are some separations and ecogenic fluid is there. So it is not clear ascites. So these are the basic investigations. What we get the information from these basic investigations. So,
Dr. Srinivas, go ahead, sir.
RSV, I think you have to unmute him.
No, sir, he can unmute himself. I've already done it.
sir.
He's a co-host. Murki, sir, మీరు ఒకసారి unmute చేసుకోండి, sir.
Now only I'm unmuted. Can you hear me?
Yes, sir, we can.
Yes,
Go
sir.
ahead.
Yes, sir.
So I was just saying that it is cholestatic jaundice with ascites without liver cell
Sir.
failure and no alpha-albuminemia. Now we have a cholestatic jaundice with ascites. So how do we explain this? And I think somebody has put it hydatid cyst. But again, hydatid cyst causing cholestasis is little odd. It will present as a mass abdomen and rupture can cause ascites. The cyst rupture into the abdomen can cause ascites. But I'm sure Subramaniam sir is much more experienced on hydatid cyst and other things. So maybe, sir, can it be hydatid cyst?
No, I don't think it is so, sir. The age-wise also, we don't come across usually such age group. I did not come across. I'm not. I don't think it fits into.
Murki, sir, Dr. Sharmila was asking if it was a possibility of TORCH or any other group.
Torch is very odd because, as sir said, this is a well-thriving child. And we are seeing the presentation at 2 months of age. And we are not talking about any hepatosplenomegaly or severe IUGR or for that reason thrombocytopenia features. So
Even
there are no other features.
There are no.
The microcephaly, sir, small head circumference.
It is not really microcephaly. Microcephaly is less than 3 standard deviation. This is on the lower centile.
There are no clinical stigmata of intrauterine infection or TORCH infection as such.
I agree, sir.
And we do expect splenomegaly, sir, in TORCH infections.
Usually there can be splenomegaly also. So hepatosplenomegaly, intrauterine growth retardation, cataracts, microcephaly, deafness, all these things, some congenital heart, all these things, if they were to be there, we can think in terms of a clinical stigmata being present for intrauterine infection. Right.
So Upender, can you help us, sir? What should we think, sir, now? Because now we have a cholestasis without much of a liver problem, and you have an ascites which is sitting there.
Yes, sir. Ascites cholestasis with high GGT is one of the clue. GGT, as we are saying, we are discussing, sir, GGT has an important role in cholestasis. So most of the cholestasis syndromes, the GGT will be it will be decreased. Like it's normal or low cholestasis. In all other cholestasis, it increases. Sometimes even the degree of elevation also gives us some clue to the etiology. Like biliary atresia.
Is there, apart from Bucciari as first consideration, is there any possibility of intrahepatic biliary hypoplasia? Sometimes it can be partial or it can be total also. So, is there any possibility? So, but they mentioned that the venous radicals as well as bile radicals are normal. Partial biliary hypoplasia also can clinically present as cholestasis if it is intrahepatic. That's is there any possibility like that? That's one thing we have to consider.
So this biliary hypoplasia we see in syndromes like Alageli syndrome usually presents with hypoplastic.
Yes.
Hypoplastic biliary drugs are either extrahepatic or intrahepatic. Both can be hypoplastic in Alageli like syndrome, or even some syndromes. We categorize all them into paucity of intralobular bile duct syndromes.
Yes.
So even Downs also can present with the paucity of bile ducts intrahepatically. Yeah? But most common syndrome is Alageli. In all other causes, it will be normal intrahepatic duct. Biliary atresia have both extrahepatic atresia and even intrahepatic ducts are also hypoplastic. In this case, anyhow, we are not thinking of biliary atresia, sir, because of clinical presentation. So these ascites we have to explain with normal liver functions.
Dr. Upender, just a query, sir. Normally, GGT is associated with liver function specifically, right? So high GGT, does it imply that there is some issue with liver functioning as such? I'm not looking at structure and organometry.
Cholestasis.
More of biliary system. GGT indicates involvement of biliary. Any biliary pathology causes elevation of GGT. So biliary either intrahepatic or extrahepatic. So biliary causes either biliary atresia, choledocholysis, sclerosing cholangitis, Alageli syndrome. All these cholestatic syndromes where biliary system is predominantly involved, they have abnormal GGTs. Except syndromes like PFC where there is a transport defect, their GGT is relatively lower size.
Upender, your discussion definitely it looks like it is a cholestatic jaundice with biliary cause because of GGT.
More indication of biliary pathology.
Yeah, this looks like a biliary pathology, significant biliary pathology. And ascites, how do we explain then?
Isolated
uncommon causes we have to think. So in this case, we have to think of uncommon causes such as there is cholestasis and there is ascites without liver dysfunction. So we occasionally come across this choledochal cyst presenting as ruptured biliary ascites with normal synthetic functions, and spontaneous bile duct perforation also biliary ascites cholestasis with normal liver functions. This could be these two are what we occasionally see, sir. There is ascites and liver functions are normal. Then our thinking goes that it could be biliary ascites. One of the uncommon presentation, but classically cholestasis preserve liver functions with ascites. So then we strongly suspect this biliary ascites, biliary peritonitis or biliary ascites, either due to ruptured choledocholysis or spontaneous rupture of CBD is known. This is one of the strong possibilities, because other things we cannot sir.
Dr. Upender, what about your comment on liver size? Sonologically speaking, do you think the liver is enlarged or is it enlarged? Is there?
Yes, sir. 6.8 centimeters. So usually in newborns we expect around 5 centimeters.
Nearly 7 centimeters. There is slight, definitely sonologically speaking, also there is a hepatomegaly.
Yes, sir.
So can we relate all these things? A hepatomegaly, a cholestasis, ascites with no evidence of liver cell failure, can there be a possibility of a congestive hepatomegaly because of some vascular episode like Budd-Chiari associated with intrahepatic cholestasis and clinically presenting as cholestatic jaundice? That is my doubt. Maybe I am wrong. That's what I feel. I'm trying to correlate, join the dots. That's all.
Can present, sir, but as we were discussing, usually in Budd-Chiari, cholestasis will be the late presentation, sir. So child presenting with cholestasis is very unlikely in Budd-Chiari. They mostly present with ascites. So whenever child present with predominant ascites, our differential will be Budd-Chiari. When child presenting with cholestasis and then developing ascites, so we will think of other causes, sir, either biliary or intrahepatic causes, sir.
Here, one more point, sir. There cholestasis is obvious. I think all of us will agree as far as cholestasis is concerned. And there is no suggestion, phonologically speaking, there is no extrahepatic evidence of any cholestasis. Outside liver doesn't be the CBD, everything is appearing normal. There is no suggestion of any choledochal cyst or anything, CHB or anything such thing. So, but the liver is enlarged, and there is a strong possibility of intrahepatic cholestasis in this particular case.
Yes.
Do you agree? Do you agree, sir? There is a possibility of strong possibility of intrahepatic cholestasis with raised GGT. Clinically, patient having a white colored stool and dark urine and raised GGT and all. Baby otherwise well. Baby must have had some intrahepatic cholestasis for a cause. The cause is to be established. I agree, but that is a clinical evidence to that.
That is what actually that it's not.
Yes, Japan, sir. Upendra garu, meer cheppandi.
Sir, sir, that is what we are discussing. Our both findings are not matching. So if it is intrahepatic cholestasis causing ascites, then definitely we expect some hypoalbuminemia and some other features of liver cell function like growth failure, edema, at least mild coagulopathy. So intrahepatic cholestasis to the extent causing ascites definitely will have other liver cell dysfunction features. So this is something we are looking for uncommon. It's not all the features are not matching fitting into intrahepatic cholestasis.
I am not stating that intrahepatic cholestasis is cause for ascites, sir. No. So there is an element of intrahepatic cholestasis. Apart from that, there is a possibility of any extrahepatic portal hypertension that could have caused some ascites. That is one thing. Is there a possibility? Because we have to explain the ascites. Somehow, of course, we have to do the other Doppler studies and also ascitic tap and others. But as it stands now.
Sure. So all that can be possible, but this is very young child, sir. All these complications of portal hypertension and portal hypertension causing ascites usually occur after long time, sir. After in chronic liver disease in older children, we expect all these consequences. So in this young child, otherwise healthy child, it's causing ascites or portal hypertension causing extrahepatic compression and cholestasis is slightly difficult to explain.
So I think, sir, this
is some acute itself, well-preserved child with acute presentation.
So Doppler study was done.
Ascitic tap can guide us, sir.
Just a minute, sir. So two things which have been ruled out in the ultrasound is it's not portal hypertension. They would have picked up.
Okay. The portal vein was. Okay.
Hello.
Yes.
Hello, sir.
Pancreas.
Hello.
Is also only mentioned.
Sir.
Yes.
Hello.
Yes.
Yes, sir. Go on.
Hello. Can you hear me?
Yes, sir. Yes, sir.
Okay. So while sir was saying that yes, this looks like a intrahepatic cholestasis like picture, but we understand that there should have been hypoalbuminemia, which is not there. So definitely history-wise, it looks like a biliary cause, and it looked like extrahepatic cause biliary cause because the ultrasound abdomen should not has not shown any intrahepatic cause. Now in the extrahepatic cause, unlikely that it is a choledochal cyst because ultrasound should have easily picked it up. Now, regarding the other two possibilities of butt Chiari and portal hypertension, again, portal hypertension would have been easy to pick up on the ultrasound. So they did not mention anything about portal hypertension on the ultrasound. That's also ruled out. So leftover is only butt Chiari.
Portal vein they have mentioned, sir?
Yes, sir. So they said portal veins are normal and there is no portal vein.
What is shown in the slide, I think here I could not see anything.
Okay. So I think, yeah, they did not highlight any portal hypertension, sir, in this. But I'm sure if that was severe portal hypertension, they would have picked up on the ultrasound. The other thing is echo was done with a special focus to rule out only butt Chiari. And echo is normal. So hepatic veins were normal. Doppler of the hepatic vein is normal. So portal hypertension is ruled out. Definitely we have ruled out butt Chiari. Then we are left out only with extrahepatic cholestasis. And we don't know why this extrahepatic cholestasis is there, but there is ascites. So that is where we will concluded, and maybe subsequent slides will help us. It will knit the story well if you look at the subsequent slides. So should we move, sir?
Next. Yes, sir. Next. So most important investigation that will guide us could be ascitic analysis, fluid analysis. It clearly says whether the ascites is due to portal hypertension or other causes or any other etiology it can lead. So ascitic fluid analysis will be of great importance in this case. Next.
So shall I continue?
Yes, yes.
Go ahead.
Yes, sir, we have done hepatobiliary scintigraphy cancer following this. Here we could see tracer uptake by liver, followed by there was diffuse dye in the abdominal area, sir. The scan demonstrates normal liver function, normal intrahepatic transit up to porta, followed by complete leakage into peritoneal cavity. No biliary drainage into intestine can be demonstrated.
So we are breaking our heads with biliary ascites. All right.
And followed by that, we had put drains or abdominal drain insertion, and we could able to the color that fluid was collected. We could see greenish yellow in color fluid collection. And on day 1, drain was 85 ml, sir. Followed by day 2, it was around 110 ml, and day 3 also it was around 80 ml, sir. It was slowly decreasing. And followed by this, we have referred many articles, sir. We thought it could be spontaneous perforation. That is the reason we had put drain, and we were looking forward for spontaneous closure of perforation. And for confirmation, we have sent drain fluid for total bilirubin and direct bilirubin analysis, sir. It was suggestive of 32 and 15.73 mg per deciliter respectively. And followed by this, we have done MRCP scan, sir. In MRCP scan, here we can observe this is gallbladder and this is cystic duct. And this is cystic duct. This is cystic duct, and whatever hyperintense foci we are seeing, these are due to fluids. And down the line here, we can see common bile duct. And common bile duct, the proximal portion is not visible properly. And down we can see narrowing. And in down slide here also we can see proper narrowing of common bile duct. And the impression was common bile duct appears to be showing abrupt tapering before insertion into duodenum, and part of CBD just proximal to tapering shows focal dilatation at its widest part, sir. CBD distal to the attachment of cystic duct shows a short segment of non-visualization, sir. This was the finding of the MRCP, sir, magnetic resonance pancreatic cholangiography. And after seeing there was a distal narrowing in the the common bile duct distal part, it itself explains that due to pressure buildup, it could be a reason for perforation, and we can't go conservatively at this point of time. That is the reason,
there is abrupt tapering before the site of insertion into the second part of the duodenum. And along with that, there is a focal dilatation. So obviously, the CBD, the bile is not getting drained into the bowel. So this could have caused some rupture of the CBD that would have resulted in biliary peritonitis. I think that's what I think I can interpret that way. CBD distal to the attachment also shows a short segment of non-visualization, means that is where it has given a given way for the bile to leak into peritoneum and cause rashes. Right.
And followed by that, and or like operation, like the procedure was done, sir. Operative procedure was done, sir. Post-operative diagnosis for hepatic duct perforation with common bile duct stenosis. Operation procedure done was laparotomy with hepatico-jejunojejunostomy with ROX10 by jejunojejunostomy. And we have given supportive medication for child like ADEK supplementation with along with orthodeoxycholic acid.
Like was actually hepatic duct or CBD, because distal to cystic duct insertion, the CBD was not visualized.
CBD
but
was
post-operative diagnosis was somewhat different.
Yes, sir. Yes, sir. Yes, sir. Sir,
Operative is more correct. More than imaging, operative is correct. But MRI wise, what you said is speaking of possibly a CBD perforation. Right. Okay.
Yes,
Okay.
No, I think it is CBD perforation only, sir.
Okay, but here it is mentioned as hepatic duct perforation. That's why I got it, because surgeon is more correct than me, you have seen. my interpretation as imaging goes, that is CBD perforation.
Yes, sir.
So it could be at the junction, sir. Most common site would be where cystic duct joins with common hepatic duct and forms CBD. That junction is the most weak point, sir, and most of the time the mural weakness will be there.
Yes.
So common site of perforation is at the junction of cystic duct and common hepatic duct, where common bile duct is formed. So might be
their perforation might have occurred. Right.
Surgeon has mentioned it as a hepatic duct.
Okay, okay, it's all right.
And sir, liver biopsy, the histopathological examination was done. Sir, it was suggestive of section showing piece of liver tissue with dilated sinusoids with deposition of bile pigment in canacula and few hepatocytes. And sir, these were the interventions we have done. That is on 31st May. Drain we have put, followed by after confirming with like HIDA scan and MRCP. We underwent like we have done child. The child was taken for surgery, followed by surgery. These were the trends of total bilirubin and throughout the synthetic function was maintained. And here we could see like a pale color stool, sir. After inserting drain and surgery, we could see the improvement in stool color in the further. This was the stool color at the time of discharge. Sir, this was the child's appearance. Abdomen was normal with a scar mark at the surgical site.
So it was an excellent case that is presented by you, and entire team. It goes to entire team who have managed excellently well.
Thank you.
Any more expert comments?
Sir, yes, sir. It's very unusual, very uncommon case, sir. We rarely see spontaneous perforation of CBD as a cause of neonatal cholestasis. So uncommon presentation, but it's classical features are there, sir. In this case, if you retrospectively analyze the case, we are going in a right pathway. It's clinically it was an extrahepatic cause, healthy child with ascites. So this, if you retrospectively analyze the case, this ascites, biliary ascites with neonatal cholestasis with ascites and normal liver cell synthetic functions. So whenever we are discussing this case, even in our postgraduate times, the first differential should be biliary ascites. Either it could be this ultrasound sometimes may be difficult to interpret. So in a very small kids, CBD size normally will be 1 to 2 mm, and it's very difficult to measure the size of CBD in neonates. So even cyst, sometimes after rupture it collapses and CBD may not be visualized. So it could even be coloidal cysts presenting with ascites, or it could be spontaneous. It's very difficult. Important investigations. Parop cholangiogram usually will help us to differentiate whether it is normal bile duct spontaneously ruptured or it is coloidal cyst with rupture. So I would like to ask, is there any picture of cholangiogram? Parop cholangiogram will help us. because there is
So-
subtle difference in management. If it is spontaneous rupture of normal CBD, there is chance that we can just repair the rent or place a T-tube, and after a few weeks, once the rent is spontaneously closed, we can remove T-tube and normal extrahepatic system can be restored, sir, if it is spontaneous rupture. Or if
So
it is
one-
collateral cyst with rupture, then hepaticojejunostomy will be the definitive treatment. So Parag cholangiogram would help to differentiate it.
Dr. Upender, my
Yes.
submission here is the CBD at the point of entry into the second part of the duodenum, there was a narrowing that was noticed. And apart from
Yes,
that,
sir.
proximal to it, there was dilatation also. There seems to be some problem with the insertion of the CBD into the second part
Lower
of the duodenum. Because of possible mechanical pressure only, it has manifested a little later. Little later and has bursted in the CBD or hepatic duct or whatever it is. I think it is due to pressure that has given the way for the bile to leak into the peritoneum. That's what I personally feel. In this
Yes, sir. That is the third cause, as we are discussing. So one is spontaneous rupture due to congenital weakness at the junction 1. Colorectal cyst is one, and third, this could be the lower CBD strictures. Sometimes, rarely we see these 3-4 causes could be etiology of ruptures.
Yes. My question to Akhilesh is, what other forms of ascites you can come across apart from this biliary ascites? What are the other types of ascites you can come across?
Sir, one more, like it could be due to synthetic liver dysfunction due to decrease in albumin, the decrease in oncotic pressure, and due to hydrostatic pressure imbalance. That's the one we could expect, sir. And one more, preserving synthetic function, as discussed in previous discussion, in case of Iaptcb syndrome or hepatic vein thrombosis, only because of increased hydrostatic pressure, there will be acute presentation. Due to that, there could be only transidative the ascites, sir. Whereas in liver synthetic dysfunction, we could see exudative ascites, sir. And one more thing is biliary ascites, sir. Due to choledochal cyst perforation or spontaneous bile duct perforation, we could see biliary ascites.
Still two more are there. So not in the young age group, you may come across chylous ascites, sometimes uroascites also. There is a leakage of urine into the peritoneum, you may get uroascites. If there is a leakage of chylous fluid, you may get a milky fluid. So that is chylous ascites. All these things are possible because the ascitic tap will reveal what it is.
Okay.
So just one point I want to add, Upender, there was another challenge was intra-para-op, all the bile ducts are inspissated.
Oh.
So they were not able to do a cholangiogram because of the inspissation. So it was another very interesting thing, and they have to go all out and do hepaticojejunostomy, although there was inspissation, because we thought that high pour out must have caused the inspissation of the bile duct. Luckily, post-op baby started showing yellow stools, and that cleared that inspissation was a transient one. So it was a difficult decision also to go for photoenterostomy or hepatico.
Yes, sir. It's sometimes it will be difficult. Even this biliary ascites, this causes inflammation around the CBD and all the portal area, and that area will be completely inflamed and very difficult to pinpoint the site of perforation. So that time surgeons will take on-table decision to in what way they can drain the biliary system. So they might have decided that the proximal duct would be patent, and they have joined the hepaticojejunostomy.
My question to Dr. Upender, how do these children fare well in the long run? See, most of the times in adults, we come across when there is a biliary tract surgery, most of them, they land with some or other issue later on also. Apart from infections and other issues, the biliary tract, how do these children, they do fare well in the long run?
Sir, most of the children do well, sir. Only issue in these children is possibility of cholangitis, sir, ascending cholangitis, because these hepatic ducts we have directly joined to jejunum without any sphincter of body.
Yes.
There is chance of ascending cholangitis.
Yes.
So, and second possibility is stricture at the hepaticojejunostomy site, sir.
Long run, they may become victims of biliary cirrhosis also. I think if they.
Yes, sir. So we should keep under. Most important complication is ascending cholangitis. That too occurs mostly in initial 1 to 2 years of after surgery, sir.
Okay.
So we carefully follow them. If there is any slightest evidence of infection, even slightest of evidence, slight increase in counts, slight derange in LFT, slight fever, we empirically start them on antibiotics and usually keep on cyclical antibiotics for at least 2 years, so that recurrent cholangitis is prevented, and by that even we can prevent the stenosis also. Recurrent cholangitis causes stenosis of the anastomosis. So stenosis and infection are two important complications, usually occur in initial years of the life. Once they cross 2 to 3 years, most of them do fine, sir.
So therefore, the stoma may get narrowed also over a period of time.
Yes, sir. So an anastomotic site, because this bile duct and intestine, there is a disproportionate in the lumen size. So anastomotic site can get stenosis, more common when there is recurrent cholangitis.
Okay. Thank you.
So we try to prevent cholangitis by giving prophylactic antibiotics, cyclical antibiotics. We keep them on.
Okay. Thank you. Very nice inputs.
Inputs.
No further queries or comments.
Sir.
So it was an excellent discussion. For the first time, I am seeing
Mr. President Dr. Bhaskar sir to give the closing remarks.
Thank you, Dr. S. During these 6 IAP PG clinics, what I observed today is the discussion was more between the experts, and I could see the interest and enthusiasm among the experts, and partly the presenter is slightly being ignored. Probably he's lucky in that way. He got less questions from your side, and you made him to pass through the examination. Here I appreciate the enthusiasm of Dr. G.V. Subramanian sir, and as well response from Dr. Upendra Shava and Dr. Srinivas Mulki. It was really very interesting case, and actually Paramita had come to our rescue when there were no long cases from other institutes because of these examinations. And fortunately, the case was so interesting. I'm sure the participants had they were enthralled by this interesting case. So thank you one and all. And I acknowledge the presence of seniors like Dr. Tilak Chandrapal, then Dr. Thudum, and surprisingly, Dr. Akhil's mother-in-law, if I'm allowed to reveal, she's mother-in-law of Dr. Akhil, Dr. Uma Devi. Dr. Uma Devi is mother-in-law of Dr. Akhil. She was also interacting on chat box. Thank you, Dr. Uma Madam. Thank you all for participating in this. Wish you all a very happy Sunday. Thank you once again. Namaste.